checklist. There is a checklist for the nurses, and there is a checklist for the RT. And if the RT is not available, then the nurse can do it. And we have a checklist for physicians. We have this yellow area where it's a further checklist for babies less than 27 weeks. And we have a checklist for imminent delivery. Anybody want these checklists? I can provide, but I'm going to pass through it because I don't want to go through all these checklists. But basically is the making history, communicating, make sure that the nurses, the RT, and the obstetrician are on the same line. The parent should be on the same line. The temperature, the sugar, the ventilation, the oxygenation should be ready. The IV set and other important medication are. These are basically what these checklists are for. We have another checklist for the baby when become 15 minutes, and for babies at 30 minutes, at different gestation, another checklist at 20 minutes. We have also a checklist for, the checklist here for 60 minutes, and we have another checklist for 2 hours. We have a checklist for transport, and we do have another checklist when the labor is imminent. And the most important point, and the most, I think the key for successful is our golden hour time frame. And you can see that we have time frame for starting everything. Before the delivery, we do the pre-delivery care plan that I will be talking about. And after delivery, we make sure that delay cord declamping, the baby received at least 2 minutes. And we make sure that the baby's CPAP start within 2 minutes, whether before or after cutting the cord. We make sure that we have an IV access within 10 minutes. And usually we have 2 trials of peripheral IV before we go to the central line. And therefore our target dextrose to hit the baby within 10 minutes. And our target for caffeine is 20 minutes. And our target for sepsis workup is about 2 hours. And you can see, and I'm sure most of people think that surfactant is an emergency medication. However, we don't give surfactant, and we try to delay it as we can until we achieve the functional residual capacity. And most of the time we give it between 30 to 60 minutes. And after achieving the peripheral IV, we start to have the central line, and our target to get the central line within 45 minutes. Our X-ray, when we were doing the X-ray, was 20 minutes, but now most of the time we don't do X-ray, almost zero X-ray, because we depend on the ultrasound, and we trained our people, including the nurses, to do the point of care ultrasound. We always do the debriefing, what went well, what are the barriers of delivery, what went good, and what is the suggestion. So how our work, the flow is start with the pre-delivery care plan, then golden hour, and then we go for care of sick baby if the baby is sick. So basically the premature care plan composed of the 3 people, and the main stem or the center of the care is the baby. So we have parents, we have the neonatologist, and we have the obstetrician, and all these 4, depending on the situation, they make the future plan. Now, if you can see, I don't know if it's clear or not. Let me minimize it. See. So I hope it works. But you can see that the premature care plan here are done by access. But if you have a system, then it can be incorporated in the system. But if you don't have system, you can have it on access as a local computer. And there are 3 parts. You can see one part are filled by the general information, and there is a part by obstetrician and the fetal medicine and the social history, and then another part by the obstetrician. And at the end, the parent should sign, and they should have no question. And you can see these are enabled, the obstetrician, and there are presets, so it's only selection. And this only valid for 1 week, and it should be repeated after 1 week. As we know, 24 weeks is a different from 25, different from 26. So after each week, we change the premature care plan, and we have another meeting with the family and also with the obstetrician for any question. We handle the parent a piece of information that is always updated. And today also, in these days, we'll give them a video, a record of what exactly we do, what the expected general questions, what will be the outcome, depending on the weight and the gestation, what is the most common complications and what is the most common intervention that we do, and what is the survival rate, the expected duration of stay, and if they have any questions, they can communicate. We have this in different languages. We have it in English, in Spanish, in Arabic, and I'm not sure. I think now is more languages are run. And you have 3 translators capsules. And the main aim of this is to increase parent collaboration, and we found that this minimized the complaint and the happiness and satisfaction of the parent, whatever the outcome is. So again, the premature care plan is very detailed one and include 3 parties: the obstetrician, the neonatologist, and the parent. And again, it should be signed and dated each time it has been done. So what
we concentrate, but I want you to watch this. Give me some.
Sorry, is there a question?
Golden hour.
Hello? Any question?
From Dubai. Just take some notes from.
I think some people forgot to mute their devices.
Oh, I see. Okay. So what are the components of golden hour? Of course, the golden hour include, in addition to the prenatal care plan, is the neonatal resuscitation, and then the post-resuscitation care, the transport to the NICU. And again, I want to stress that we don't call it transport, we call it mobile NICU. The cardiorespiratory decision-making in very sick baby are vital. And the most important is on arrival, you check the most important outcome and predictors are the sugar, the temperature, and the saturation. And then it includes also the initial course in the nursery. So what gentle care means less harm, best benefit, less invasive, start feeding as early as you can, start aggressively with TPN, avoid unnecessary lines, try to avoid intubation, always ask yourself if the tests are needed, avoid X-ray as much as you can, it's best to be 0 X-ray in an ICU, and avoid nursing frequently. Always ask yourself, do I really need to touch that baby? And cluster the care. And empower the nurses to prevent people are checking and try to cluster care. And we do cluster at 8 a.m., at 1 p.m., and at 6 p.m. For round, for examinations, for procedures. And we do all that in the same time and with effective sedation. We don't do wait in the first 3 days. And we have what we call it the IVH bundle, including the positioning, avoidance of movement, avoidance of the boluses. And I consider boluses even the light and the noise. So we're increasing the peaceful time and avoiding the noxious time that the baby might have. We avoid boluses as much as we can, such as normal saline D10. And if we are obliged to use it, we try to use half of it and extend the period. So instead of using it over like 30 minutes, I will give it over one hour. And instead of I give 1 ml, I give 2 ml. We also involve in the gentle care, we involve the family, including the children in the round and in the, what we call it family or integrated care. And also in addition, holding the baby and controlling the temperature and give better neurophysiological outcome. We are very meticulous about the positioning of the baby and nesting and neurodevelopmental care. And we have a dedicated team, and we have round on Tuesday for neurodevelopment by special team, not part of, but they are always collaborating with the managing team. We have lots of subspecialties that's helping us: cardiology, pediatric surgery, neurosurgery, infection, neurology, urology, hematology, genetician, neurologist, radiologist, ophthalmologist, and the list go on. But also we have other disciplines such as OT and PT. We have the dietitian, social worker, pharmacist. We have dedicated pharmacists, clinical pharmacists in unit. we have feeding educator, we have the feast team for feeding problem, we have the SWAT team for skin care, and we have the VAT if we cannot do the vascular access. What other things we do is what we call it smart monitoring, no numbers. And I think at some point, people will realize that numbers are not important, including blood pressure. When I was graduated, I used to say, well, 24-weeker mean blood pressure is 24. And mean blood pressure is nothing than a number that is calculated. And then we moved, no, number is not enough, we use centile. And then we discovered even these centiles are not important. So we moved from moving toward numbers toward pattern recognition, circadian rhythm, event-to-event variability, scatterness, skewness, centralization, lateralization of these numbers. And I'm going to show you some slide that I do on smart monitoring. We also do POCUS, point of care ultrasound of the head, of the lung, of the bowel, of the heart. We do ultrasound guided intubation and ultrasound guided vascular access. We're trying to achieve zero X-ray. We don't give sodium bicarb. We use alternatives. We have integrated hemodynamic assessment system. And again, surfactant is not an emergency. Setting up the CPAP, the caffeine, and the sugar, and the temperature, and the saturation is way to go. We use surfactant tool for giving surfactant, and we use elective jet for babies less than 28 weeks. We use something called dynamic PEEP, or dynamic CPAP, so we don't use any more CPAP, we do dynamic CPAP. So we put a range of CPAP in different gestational and postnatal age and different situations. And we do also lung ultrasound guided lung recruitment for ventilation, ultrasound guided surfactant administration. And also we train nurses to look after at the ultrasound at the position of the ETT. And also you know that when you do X-ray and you have very small babies, sometimes you find that the ETT end is up sometimes, and this is mostly positional. Whenever you turn the face, the position change. And you can do only one X-ray at a time. However, you can do zillions of X-ray each time you want, whenever you move the baby. And therefore, it tells you exactly what's the best position of the baby regarding that ETT. So these are one of the things that I found it very helpful and minimize exposure to the X-ray. Now we have very complicated decision making regarding the hemodynamic assessment or objections. So we have the conventional physiological monitors, such as blood pressure, such as heart rate, saturation, whether by NIRS, near-infrared, or by pulse oximetry. We have also the demographic data that we use, and then we have some lab results. But we have circulatory assessment. We use heart POCUS to exclude congenital heart disease, PDA, PPHNs, and we do cardiac function assessment. But also we use near-infrared spectroscopy. We use, visible light is not the only way to go. There are other things that we can see the newborn baby. So for example, a snake cannot see the visible light. They only see the thermal imaging. So why we don't use it? So we use other means to look at the baby, such as infrared technology. We use high-speed camera where it can show you the color changes and the movement changes that is not visible to your normal eye. As you know that your eye can see 25 frames per second, and you can see only a visible light between 200 to 600 nanometer. And therefore, if I take 3000, for example, you cannot see the bullet moving because the bullet moves 300 frames per second. And therefore, if I do 700 frames, then I sample it and put it back together and move it, then I will see things that I don't see. For example, I see the face going red and pale with your heart rate, and therefore I can measure your heart rate. We use tachogram. The tachogram can tell you the physio feature of the baby. It can tell you the pattern of the baby for each parameter, whether it's a blood pressure or heart rate. We use the point care. The tachogram, gives you the variability. It can tell you whether the baby, for example, in pain, whether the baby is comfortable, not comfortable, whether he's okay with the pleasant stimuli, but also we use point care. This will give you a marker, a shape of your physiological output, whether it's a heart rate or a respiratory rate. And in that shape is different between different babies, and sometimes different between diseases. So for example, you can have a 24-weeker shape, but when the 24-weeker sedated, will have different shape. And I'm going to show you some tables and some pictures. We use frequency table, and we use respiratory. We don't depend on the respiratory assessment much on blood gases. We depend on loops and graphics, and we love non-invasive. We do also line POCUS, of course. And we also include the objectives of clinical evaluation, such as capillary fill or urine output and others. We use also the subjective things, such as, color, activity, feeling. Somebody say, well, I'm not happy about that baby. We use also the bowel POCUS. We measure also the subeomesenteric artery and splenic artery Doppler, and we use somatic, whether it's a bowel or kidney NIRS, to check the local saturation of these somatic, in addition to the, of course, the NIRS of the brain. And therefore, that all give the clinician all the analysis, but he or she will use her or his intuition and experience and the evidence base and the opinion of others to do the decision, and then we can make the decision in very sick babies. What other tools that, as I said, we use ultrasound guided intubation, ultrasound guided vascular access. We use the FOL protocol to administer the fluid and give the Lasix. We do smart monitoring. We have, of course, the CNN, very good network that give us the feedback, and we use the EPIC for quality control and quality assurance. And of course, we have the facility to benchmark with other units. So what the antenatal care management that we do? Of course, we have the intrapartum antibiotics. We have the antenatal steroid. We give, of course, the magnesium sulfate to protect the brain. And we have a list of cesarean section. And the reason for this list is the expected complication and expected duration of actions, both from the obstetrician and the neonatologist. Of course, we do have antenatal scanning on a certain gestational age of the fetus. We do fetal echo and fetal maternal unit, very active. We provide very clear guidance, written and multimedia information to the parent. We have very good NICU tour, and we have lots of support group, whether it's a religious or community or governmental. We do have staff meeting for briefing and debriefing. We talk about gentle care always, of no harm, unnecessary tests and intervention, early feed, and aggressive TPN. Debriefing, team assignment, respect, and clear information. In resuscitation, I don't think we are different from others. So we start with the third 3 questions. And if it's baby yes, then he or she goes to the well baby care. And if the answer is no and need a little bit of support, then we go to monitoring care. And if the answer, the baby did not respond to initial steps of resuscitation, we go to intensive care. So I'm going to pass this because I want to show more important things to you. Of course, we follow the algorithm of resuscitation of the NRP. And we check the saturation in by two means. We do the pulse oximetry in the right upper hand to do the preductal, and we have the target saturation that we do, and for preterm and term, but also we do the somatic and cerebral NIRS. And the effectiveness of somatic and cerebral NIRS, because as you know, the pulse oximetry is more arterial weighted, while the NIRS is more than venous weighted. So the pulse is almost 80% represent the artery, while the NIRS about 75 or 80% represent the vein. And therefore, if you find the difference, you can find the oxygen consumption rate. And because you have blood pressure and you have the cardiac output, you can measure the peripheral vascular resistance. We measure the heart rate by different means, including stethoscope or palpating, but our main goal is to have the heart rate from the ECG. We use the target preductal oxygenation depending on the postnatal age, and titrating the oxygen according to that. And we do post resuscitation team debriefing, what went well and how we can improve, and what about the staff feeling of communications, whether somebody was rude, whether the tone was high, or sometimes the outcome is not great, some people are not expert. We are very open to that, and we're always trying to improve. So what is the post-resuscitation care that we provide? I don't think we are different from any. So it depends whether there is apnea or gasping, or the heart rate less than 100, or the breathing is labored, or the heart rate less than 60. And the most important in post-resuscitation is when and how we start the sugar and start the fluid, and how we start CPAP and start caffeine, and when to start the lines, whether it's a peripheral or central, and the most important, the challenging, is the surfactant, and when we do intubation, or how we do mechanical ventilation, whether we go elective high frequency jet. I think in UK there is no jet, but I think you guys have the high frequency oscillator. Now we have a list of failure of resuscitation or initiation of resuscitations, and there are different causes. I'm not going to go through it because I want to discuss the more important things, but there is failure to respond to primary ventilation, and there is usually local problem, or there is lung issues, whether it's acquired or it's a congenital, and whether there is a congenital heart disease or heart block, or there is a brain issue such as a brain injury, or some congenital rare neuromuscular disorders, or there is some mother was taking some medications as a part of medication action on the baby, or a part of withdrawal. And then we decide to go for further resuscitation depending on the next question, whether the heart rate below 100, or we have a labor breathing or cyanosis. But again, our main goals after stabilizing the baby is when to start the sugar, when to start the CPAP, when to give the caffeine, when to start the line, and the timing and indication of surfactant. It's vital and more important than anything else is to control the room temperature. And you can do that, many teams control the room temperature by bringing it up to 36, about 36 degrees Celsius. But also you can do different other things, that swaddling, skin to skin contact, using plastic bag, warming pads, or pre-warmed radiant heater, and use humidified heated oxygen and incubator air. And remember that you need to prevent both hyper and hypothermia. Now we have very strict protocol about delay cord clamping, and we like to go to 3 minutes. Sometimes that is not possible, and we do placental transfusion during resuscitation. So we resuscitate while the cord is still connected, and we do both, whether it's a vaginal or it's a cesarean section. But always there is a discussion when to terminate, but we love to go up to 3 minutes. We have very clear protocol to do the placental transfusion on normal delivery and in C-section, and we can do it with the respiratory support. Unlikely that you need still connecting the cord and you can do chest compression, or you need to give medication. That is very unlikely. But the most important point, in my opinion, is the respiratory support. Also unlikely that you need to do intubation while you can stop the end, but most of time is you need to start CPAP and give PPV while you're doing the placental transfusion during resuscitation. The airway is the timing, and I'm going to bring you again to this picture again and again. Our timing of CPAP should be 2 minutes. Suctions, only peripheral, never allow deep suction. When to intubate and what to use ventilation. And again, when very small baby, we use the jet ventilation. We, of course, use pressure limited, volume targeted, and we have a strict guideline about how to supplement the oxygen and how to monitor the gas, whether it's invasive or non-invasive. But again, we depend mostly on loops and graphics for our ventilations. Now, the question always, people are very interested to intubate and give surfactant, but guess what? That is not always the case, or almost not the case almost always. So we have the surfactant tool, and I'm happy to provide it to anybody ask me for. But in short, it's saying that Whenever the FiO2 requirement is more than 30 minutes for more than 15 minutes, whatever your support is, you probably need need to give surfactant. So again, it's a 15 minutes wait. So it does not mean to intubate and give surfactant right away. Again, if you have persistent CPAP of 8 centimeter water, you might need. If you have a clinical increase of focal breathing, you might need. And if there's a sign of RDS on lung POCUS. If the CO2, and if you're lucky to have a gas, and if it's a CO2 more than 60, then you might think of giving surfactant. We always give surfactant as early as cool, between 30 to 120 seconds, but always we balance it with the need of effective CPAP. There is no point of thinking of giving surfactant and your CPAP is not effective. Now, there's always think about mist, or I think in UK called LISA, but we have our own method that called ECAL mist, or early CPAP and large volume minimal invasive surfactant therapy. As you know, we use BLESS and it's 5 ml per kg. I have a very nice study, was published in 2013 about the procedure. So we use the vascular catheter, the 16 gauge catheter, angiocath, and the reason for using it is a little bit soft, but you can mount it in the way you need it. So you can compare the size of the vascular catheter to the angiocath to the ETT tube 2.5. We label it and we start to use it. So this is a short video, but it's very fast. And if somebody wants to watch it, I have it on my YouTube channel and I can provide more videos. But this is basically what is. The baby is already on CPAP. This is my colleague, Dr. Yasser, is doing it. And you can see the baby is already on CPAP, and it's a volume variable flow CPAP with a generator. And you can see that he will insert the vascular catheter while observing the pulse oximetry. And then the helper will connect the syringe to the hub of the vascular catheter. He will inject about 0.5 ml, and then he will disconnect. And the reason for disconnection, to see the surfactant moving up and down or coming back to you as a clue that the baby is actually breathing in the tube and you are actually in the trachea. In addition, if you are catheterizing the trachea, you will see the vital sign changing. And then he will push it slowly over, this is being cut. And then at the end, when he finished, he will disconnect again and flush it with air, and then take it out, and the baby is breathing. And you can see we did not do an X-ray, we didn't do even a lung ultrasound. We've depend on the vital signs and the clinical signs that we are actually in the trachea. And the results are actually great. And see the baby is on CPAP, no need for sedation, and it's very short time. And now you can see that some people will say, oh, this is short, but also giving the surfactant through ETT is also short. But we're talking from the time of intubation to the time of taking the tube out. And that's, in my study, showed it's at least 17 minutes. And in ECAL mist, it's only like 3 minutes, the mean. And not only that, it would be very hard for somebody who's taking care of the baby to take the tube out before making, well, I have to see the X-ray, well, I have to do a gas, I have to make sure that the baby is breathing, and so on. So if we cannot give the surfactant through minimal invasive, we think of other. Now, when we give surfactant, we think of about the volume because we use the BLESS. We use the BLESS, which is 5 ml. And then we think about the duration of giving surfactant and how we give it. Are we giving it in invasive or minimal invasive or less invasive? Are we giving it through open NG or closed multi-access catheter? Do we use single or double lumen port ETT? Do you use hand ventilation or mechanical ventilation? Do you use X-ray to check the ETT tube? Do you use RSI to sedate and calm down the baby? Do you use the lung POCUS to guide you through giving surfactant? And the most important point, that surfactant is not an emergency medication. And in my study also, I used thermography to look at the surfactant administration. As you know that, I'm going to stop here. As you know that the body temperature is around 36.5 to 37.5 degrees Celsius. So the maximum is 37 if the baby is not febrile. And the skin temperature can go down to 32 or sometimes 31 in peripheral. So for the camera, the body temperature is between 31 to 37.2. And the room temperature or the surfactant by best would be room temperature. And the highest room temperature is 25. So there is difference between the lowest body temperature and highest temperature of surfactant is between 25 to 31. So if I set the camera baseline at 29 and use it in a very small babies, like less than 1500 grams, I can see actually the changes of temperature on the body. And the body for the camera, because the baseline is, or the baseline of the temperature of the camera is the 29, and the minimal temperature of the body is 31, then the body for the camera is red. And while the surfactant, because it's, maximum can be, most of the temperature is 21, but it can be up to 25. And so therefore for the camera, the temperature of the surfactant is blue. So if you give surfactant, you can actually see the surfactant while giving the LISA going to the lung, and because the baby will compensate right away, it right away will disappear. So this is another tool that you can use it to assess. It's non-invasive, it's cheap, it's continuous, and it's baseline. These are the type of surfactant, and again, we use the bovine lipid extract surfactant, the plus, and it's a Canadian made, and it's only like the 5 ml per kg, so it's a big size. So this is the way we give, this is another picture of ECALMist, and you can see that I am here connecting the vascular catheter already, and I'm marking it. And you can see after I'm putting the tube in, I'm gonna inject the surfactant. Of course, I have to make sure that the surfactant is in, and I'm water, you can see the movement. I have to see the movement. You can put it back. You can see the CPAP is on. And you can see I inject the surfactant, and then I will move the disconnect, flush the catheter, and give the surfactant again. For Ensure, we do a multi-access catheter. So I hope the video will work. So you can see that the baby is already on, this is in the labor room. So the baby is already on RAM cannula, and we're giving CPAP. So I intubated while the baby on RAM cannula. You can see that I've connected the CO2 checking buy-in. And you can see we use the flow inflator, and we don't use the safety valve. We control by the RT, by the thumb and index as the valve. And you can see we use the multi-access catheter to connect, and we inject surfactant while we are bagging the baby through a flow inflation valve, and we give the surfactant in 2 aliquots. Watching the baby. Sometimes I give it through 3, depending on the tolerance of the baby, and it depends also on the stability of the vital signs. Okay, and I start to stop giving when I see a struggling of the baby. That means I'm obstructing the upper airway. So I pull the surfactant out, and you can see the baby. Now, the reason why this is good, because I'm using the negative draw force, the positive draw force, and the surface diffusion of giving the surfactant. And I'm not allowing the lung to de-recruit, so I have no de-recruitment damages. And therefore, I don't need to re-recruit, so I avoid the re-recruitment damages. Our meconium stained procedure, it is the same like the NRP guideline. We don't have a changes whether or without meconium stained LICA, but we expect that the pulmonary hypertension and other complications of the meconium. So we have automatic hemodynamic assessment when we have meconium LICA in respiratory distress patient. As I said, we use the NIRS, the infrared NIRS for any sick baby, and we've checked both the somatic and the brain. And as you know, the somatic is having the auto-regulation. So you can see the automatic is always high and going up and down and fluctuating. While the CNN one, you see that, that the CNN are very consumable for oxygen, and this NIRS check the venous or assess the venous. And therefore, always the CNS is lower than the somatic, and it's always fixed because the auto variability of the somatic to maintain the oxygen consumption of the brain is fixed. And therefore, this is very early sign. So once you lose the auto regulation, you will lose the variability and the fluctuation of the somatic. And then you'll see that the consumption of the somatic dropped and become below CNS because the somatic organs want to do whatever possible to save the brain. So monitoring the NIRS, and in addition, because it's a venous and you have the pulse oximetry, you can actually calculate the oxygen consumption rate. And the best area to calculate that is the brain. And the reason, because the brain uses most of the oxygenation. And because you have the blood pressure and you have the cardiac output, you can actually calculate the peripheral vascular resistance easy. And again, by then you have the pulmonary vascular resistance, and that would help you to make all the decisions. When we follow the NRP guidelines of supplementing oxygen, so we do start at 30%, between 21 to 30% for babies, 21% for babies more than 30 weeks. And we start somewhere between 30 to 21, below 30 weeks, depend on the gestation. And of course, we are guided by saturation and NIRS. And the most important point is never give unblended oxygen. So you have to have a flow and you have to have oxygen, and then you have to have the set oxygen, set flow, and also the measured oxygen. So no unblended oxygen or pure oxygen to premature babies. Now, when we do positive pressure ventilation, we mostly depend on self-inflation bag. However, this needs very expert people, and we don't use safety valve. So our RTs use their hand to, because that gives them better sense of the inflation and prevent damages. However, we can use a self-inflated bag or the TP resuscitate. And sometimes when we have a problem, we use the LMA. Now we have very clear guidelines for the position, for the suction, for the seal, and for the initial breaths, and how we use the POCUS, whether to guide us to intubation or ventilation or giving surfactant. And I'm going to give you to this, the timetable of golden hour. We start the CPAP within 2 minutes. We alternate mask and prong. We use the variable flow even in the labor room. We use the flow inflation bag, and sometimes we use the Neopath. The level of CPAP, I start very high in a premature baby, but I start with lower in more term baby. So we don't have CPAPophobia, but we don't have also CPAPophilia. So we use something we call it dynamic CPAP. So what does that mean? Sorry, is there a question? Should I stop?
No, carry on. We've got 10 more minutes before the break. Yep.
Okay, so if I'm moving fast, tell me or stop me at some point.
I will do, yeah.
Okay. So we have what we call it dynamic CPAP. What does that mean? Is we set a minimum and a maximum CPAP for the nurses and resident. And that set of numbers depend on the gestation age, depend on postnatal age, and depend on the condition. So usually if I have a telangiectatic lung, I start with high, and then depending on the lung POCUS, depending on the saturation, and depending on the performance, I go down until I reach a point where I have a match between A and B lines on the lung ultrasound. Or if the baby is term, for example, and TTN, and there is risk of stiffness and risk of pneumothorax, I start below and I give limit to go up. And the nurses, and then I can determine what is the best high for this patient and what is the best low, depending on the B lines and A lines on lung POCUS, depending on the Doppler of the pulmonary veins and the collapsibility of inferior vena cava and variability of the systolic function on the aorta. And then we can decide what is the this dynamic CPAP is. Of course, we have very clear guidelines for intubations, tube size, how we tape and fix, and we never allow intubation without RSI. And in my view, is a barbaric action to give intubation without actual sedation. However, unless it's emergency and it's a life-saving. And then we have a procedure of how to assess the intubation, including clinical and CO2 detector, whether it's a CO2 detector or it's a capnography or capnograph or calorimetric. And then we determine the tube level. And we use the signs on ultrasound, which is the goose sign for correct placement. We use the excursion of diaphragm and sliding of the pleura, but also we use the number of rings, the tracheal rings, and also the position of the end of the ATT from the upper end of the sternum and also from the arch of aorta to guide us what is the best position of the ATT to avoid a high level and a lower level, and to prevent building up CO2 or washing CO2 and leak, and also preventing us from self-extubation. Chest compression, I'm not gonna through this. If we needed training, timing, starting, corporation, ending, and when we use the dose. Now, we have a very clear guidelines or gentleman agreement to avoid boluses as much as we can. And the boluses are actually not only the IV. The bolus can be sound, can be light, can be hold, can be movement. So in general, if you need it, try to make it less. If you decide to give 10, give 5. If you decide to give 20, give 10. And if you decide to give it over 30, give it over 1 hour. And always calculate the total fluid intake and total fluid actually received. But the main goal, try to make small doses longer. And the reason for that, any action has a reaction. So the more bolus, the more reaction. So the outcome usually is not good. So if you monitor the NIRS and you monitor the lung ultrasound, and also you monitor the your hemodynamic assessment, you will see, or especially the invasive blood pressure, you see the devastating changes when you give boluses. We have very clear guidelines about the central line and peripheral lines, the umbilical catheters, the PICC lines, cut down, the surgical line and arterial lines, and the fluid that we should give, whether it's a normal or half saline or sodium acetate, with or without heparin, the infection control, and we have very clear check to look after the line pressure every day, and sometimes 2 to 3 days if the line are very precious, 2 to 3 times a day, because that can tell you 12 to 24 hours before the line is actually blocked. We are very meticulous about stopping resuscitation when it's not necessary, and we go with the guidelines about that. We are very, very clear about when to hold the resuscitations, and we work that with the obstetrician and with the parent when there is clear 0 chance of survival, whether it's a gestation or it's a wait. We also, if there is a congenital malformation or terminal chromosomal abnormalities. And always we say, if the survival is unclear or that decision is gray, then the parent wishes should be respected. But in general, resuscitate, move to the NICU, and then discuss later. We have very clear guidelines about the comfort care, and that should include the providing oxygen, preventing complications, and most important, pain and sedations. And it should be working with the parent, and parent wishes should be respected. We have very good staff support, including open discussion. We attend the funerals of these patients. We follow up parents. We give them call after 1 year. We have relaxation session and massage for the staff, and 1 day off for those exposed to tragic situations such as death of babies. We have very good psychological support. We have very free reporting. So we don't go with the hierarchy. We don't go with the line of management. Anybody can report to anybody. And we have very free complaint system. And we have accountability. So everybody is accountable on his or her own action. Now, in my point of view, that there are 3, if you tell me what are the 3 most important factors in determining the resuscitation outcome, I would say that temperature, the sugar, and the saturation. So our target in timing the sugar hitting the baby is 10 minutes. We can do whether that's a peripheral or central, and sometimes we cannot do in both. So we give glucogel. Now I know that glucogel are indicated for babies more than 35 weeks. However, if you don't have central line and you are failing the peripheral line, so what is the best? Having some effect on the bowel or having some effect on the brain. So although the guidelines are very clear about that, but we always like to keep our sugar within the acceptable level, and usually that is 2.7 millimole per liter in less than 72 hours, and it's more than 3.3 millimole per liter in more than 72 hours. In my view, the timing of sugar hitting the baby is vital. We use, of course, depending on the situation, we use D10, D12.5, and sometimes D15. And guess what? We can do that in the peripheral IV. And if you need the peripheral IV for more than, you need more than 12.5 for more than probably 24 hours, you better think of central line. We avoid boluses unless it's glucopenia. And that usually occurs when it's 1.7, 1.6 millimole per liter. Now we have very clear guidelines, as we've discussed earlier, about the hypothermia and hyperthermia, such as turning up the temperature of the room in C-section and the labor room up to 27, 26 degrees Celsius, using pre-mom mattresses, using radiant warmers, using transport incubator that can provide whatever humidity and temperature we like. But also we don't like hyperthermia and skin burning. So temperature, and one of the goals or one of the indicator of good performance is the temperature on arrival. I moved to some units, and guess what? The temperature on arrival sometimes unrecordable, while the doctors was happy because he or she was intubating and giving a surfactant. And for some reason, that is intubation, holding the tube and putting the tube in the upper airway and giving surfactant is a sign of good performance and sign of being proud. But I think that is not the way to go. And I think we should not give surfactant until we're controlling the temperature, the saturation, and the sugar. And I think we should not give until we have a good functional residual capacity before we decide. So timing of CPAP, timing of sugar, timing controlling temperature is the way to go. So again, about the postnatal and work, what blood work we take. Now, we try to limit the blood work as much as we can. And we don't do blood work unless we need it. So some of the blood work that we do is the complete blood picture, blood grouping, culture. We try to avoid CRP. Yes, I don't do it like, once every 6 months. And we always start prophylactic antibiotics. We do gas, of course, we depend on CPG. And unfortunately, I saw some people depend on VPG. And VPG should not be used in an ICU. The only indication, in my opinion, of VPG is when you want to calculate the oxygen consumption. When you have APG and you have VPG, the difference is how much the baby consumes the oxygen. I think that only indication of VPG, sometimes it's indicated in older babies in diabetic ketoacidosis and other things. But the APG is way to go, because in APG you can depend on the CO2, on the oxygen, and on other calculated values such as the pH. But in CPAG you can depend all of that, but not the oxygenation. And we have very good guidelines for giving blood, giving back the baby the blood that we take. And remember, when you start the replacement, I don't know where you guys will start the iron replacement, whether it's 14 or 21 or 1 month, you always calculate the maintenance, considering the blood, the bloodlet, the phlebotomy that you did, and whether the baby get the transfusion or not. So please remember to replace what the blood you took from the baby by iron. That is very important for survival and the iron level and avoidance of decrease in oxyhemoglobin. Antibiotics, that's the big problem. So we all know that antibiotics sometimes is life-saving, But also we know that antibiotics have a side effect, having neck, resistance of infections, chronic lung disease. So a clear guidelines. And remember one thing, if I can give you a message, as I give you, it's always correct to start antibiotics, but it's always wrong to continue antibiotics when it's not necessary. And remember, when the baby gets sick, this baby is not a pin. Baby is not a trash that you throw everything. You throw all the garbage in this. When the baby is sick and the blood culture is negative, especially if you have two sites blood culture, think of other things than infection, and don't escalate and increase and add more antibiotics. It does not make any sense. However, we have a clear guidelines of giving antibiotics when the white PC count less than 5,000, and their mom was in labor, GPS are not treated, or there is previous family history of sepsis or neonatal death. When you have a PROM, you have sign of chorioamnitis, foul smelling liquor, leukocytosis, tender uterus. If the baby is in fetal distress or mom in labor, respiratory distress, baby acidotic, hypotensive. And, again, inflammatory markers, I cannot take it out, but usually I don't do it. We start usually ampicillin and gentamicin. We were doing the antibiotics for 48 hours, but now we stop antibiotics at 36 hours. Now the yield at 24 hours, the yield of blood culture, if you have one side, is about 70%. You're truly negative when blood culture. At 36 hours, the yield about 88 to 89. While at 48 hours, the yield is around 96. So when you stop the antibiotics between 36 and 48, and especially if the baby is improving and there is no, if the baby is not improving, probably I will continue to 48 hours. But if the baby not improving and the baby is symptomatic, and we're giving antibiotic just to rule out sepsis, then I would stop at 36 hours. Caffeine, I think caffeine can save more than 25% of babies from being intubated. So targeting to start caffeine within 20 minutes, I think is the way to go to avoid lots of intubation. Because many babies are intubated, when you give them PPV, they improve. When you stop, they don't. When you put them CPAP, they don't improve because they stop breathing. So having the sugar and the caffeine already primed and prepared before the delivery, and having a peripheral IV set, and having 2 port and one nurse putting these, and those are calculated depending on the best expected weight. If you cannot measure the weight on time, is the way to go. So you should start your sugar within less than 10 minutes. And not starting, but it should hit the baby in less than. And remember to prime your giving sets so you can hit the baby immediately with the sugar and with the caffeine. So if you can timetable yourself to within 20 minutes, that is the way to go. And of course, giving the maintenance. And usually what I do is, that is not evidence, but I usually use with the half dose, and I do have the maintenance. Or I do sometimes full loading dose and have the maintenance. And then if the baby start to have more apneas, what I do is I give another mini load, and then I optimize the maintenance. I make it double. So if I go with 2.5 milligram per kg of caffeine base, I give mini load, and also I optimize. So I found this helpful to prevent babies from being intubated. Now, whether to give oral or IV depend on the situation and depend on the gestation. When to stop, I think this is out of the scope of this talk. There are different, and then of course the side effect, you need to consider the side effect of caffeine. We have to talk about post-resuscitation complications, whether it's a CNS complications such as apnea, seizure, and the ischemia. There should be clear guidelines of starting the treatment and the cooling for the HIE. We have also to think about pulmonary complications and RDS and how we manage that. Most important, pulmonary hypertension, and do the point of care heart, and checking for pneumonia using ultrasound, pulmonary leaks by ultrasound, and diagnosing transient tachypnea from TTN by transient tachypnea from RDS, from meconium, from pulmonary hemorrhage by lung POCUS. The big dilemma, the hypotension. Now, so if I can tell you something from this talk is to avoid numbers. Don't use numbers. Don't depend on the numbers. They are wrong. And remember, there are two ways to measure the blood pressure. There is the Korsakoff sound, but also there is the oscillometry. And if you know, the oscillometry depend on the PPT or photoplethysmography. And it measures the photoplethysmography at 2 points to give you the PTT, the pulse transit time. And the pulse transit time has a margin of error about 20 in numbers less than 40. So when you have a blood pressure of 25 on the oscillometry, you're actually ranging between 35 to 5. So having these numbers mean nothing. And when we depend on these numbers, even if they are centiles, we depend on these numbers to give, volume expander. And the volumes and the boluses are very detrimental effect on the compensation of the baby, whether it's inotropes or vasopressor or it's a volume. So in my view is you depend on the trend. So you measure whether you're using peripheral and monitoring it on the monitor, measuring the peripheral blood pressure by appropriate cuff over, every 10 minutes or every 5 minutes over first hour, or every 10 minutes over the next hours, and then every 15 minutes after. And then you will have a couple of numbers. And if you compress it, you'll have a shape. And then you will see the relation between the systole and the diastole. And also you'll see your pulse pressure. And if you have invasive, then that will be way better. And I will show you some pictures about things that blood pressure is okay, is 10 and people giving pulses, while sometimes the blood pressure is 35 and actually the baby need intervention. So in addition to avoid numbers and use smart monitoring, you need to do hemodynamic assessment, whether it's a heart or the lung or the brain. And NIRS will be affect you. And clinical, remember the clinical findings are blunted. And the best would be the heart rate, and the heart rate changes it takes about 5 minutes to 10 minutes to respond to hemodynamic instability, and the blood pressure about 30 minutes. While the others, such as urine output and lactate and capillary refill, they take long time. And remember, the lactate have something called lag time, or the percentage of worsening and the percentage of improvement of the lactate after the level you measure. So the lactate will not build up until a couple of hours. And if you find a lactate of, let's say, 10, it will not improve right away, even if you give corrective treatment. You need to give it time because there is lag time. So you need to calculate your lag time depending on the lactate level and the gestation and the postnatal age. And then you expect the improvement with or without intervention, and then you decide intervention. So if you give some intervention for lactic acidosis or metabolic acidosis, don't expect the changes to happen to within 30 minutes or 1 hour. Just give it time. And of course, you need to think about steroid, when to give it and how to give it. And remember to use the pattern recognition, whether it's a circadian rhythm, event-to-event variability, the relation between systole and diastole, the pulse pressure. Is the systole going away from diastole, or the systole actually meeting there, or they are moving together, or they are changing? And especially if you give intervention, what are the actual changes of this pattern? Of course, in the postnatal care, you need to do blood work such as electrolyte, renal function, liver function, sometimes coagulation profile, and that depends on your unit. Things that you need to avoid is the naloxone and sodium bicarbonate. There is no point of these medications unless you give clear PPV and CPAP, and the mother was on narcotic, and you give the baby at least 10 minutes, but the baby is improved. And when you decrease your respiratory support, it worsens again. Then you might think of naloxone. However, you always need to avoid sodium bicarb because it will give you a safety of improvement. Your blood gas might be good, but remember, on cellular level, you are not. We have very clear guidelines and very clear cooperation with the surgical department about gastric cases. And gastric cases are very common in Manitoba. It's like a flu. I don't know the reason why, but we have we see gastric cases 6 to 7 a month. of omphalocele and sternal obstruction, spinal bifida, congenital heart disease and our cardiac center, congenital diaphragmatic hernia. We have very clear registry with the Canadian Neonatal Network about the CPAM, imperforated anus, and other complex malformation. Now, I want to stress again, please avoid boluses, whether it's a fluid or medication or a sound or a movement or a light or a sugar or a ventilation or a sedation, whether you want to withdraw the medication or care or you want to support the care, or whether you want to treat acidosis or alkalosis. Remember, whatever you calculate, go have and prolong the duration. Remember, whatever action you do, there is reaction and consequences of your actions. Now, as I stated at the beginning, is it really only we can see the baby by visible light and by linograph, by the vital signs that the monitor give us? And the question is no, we have other means. We have the thermal camera that can show us the temperature. We have the high-speed visible light camera that can show us the movements and the color changes that usually we cannot see. We have the CGI, the computer graphic imagery, that can help us to build up the baby in an imaginary like avatar inside the computer. We can use the Kinect to watch the movement, the joint flexion and extension. We can use the movement, you can monitor the movement of the chest and the abdomen by RIP, respiratory inductance plethysmography. We can monitor the electrical changes in the chest by using thoracic impedance plethysmography. We can use the leap motion to measure the local and the global movement of the baby. We can use the NIRS, the near infrared spectroscopy, of course, the ultrasound, especially the point of care and CT scan and MRI. How we can present this? We can see it as a real time, but also we can present as a histogram or tachogram or point Cray or frequency table and other means. Should I stop here, Dr. Sharma?
I was going to say, what I was going to do is open the audience up for a 5-minute break.
Okay.
After which, what we could do is we could ask, go through some questions with you.
Sure. I do have about 30 slides remaining, so not much.
Okay, that's great. What we'll do is we'll reconvene in 5 minutes at 3:20, and then what we might do is have 10 minutes of questions and then finish the rest of the presentation.
Sure, sure.
That's great. Thank you so much.
You're most welcome. I'm very open for questions.
So guys, I'd encourage you all to write your questions down. And if you could write them down as we go along in the chat section, then actually I'm happy to moderate those questions. Yep. Thank you. And if you could just all mute yourselves, keep yourselves muted.
Questions? Should I read the question or you read it to me?
Shukran.
Should I read the question, Dr. Jha, or you read it to me?
Could you please tell more about this near-infrared spectroscopy, please? How to use it and what's the benefit of it? Thank you.
Okay. Well, thank you. Thank you for the question. You know, using NIRS is a little bit long talk. I do have online course if somebody interested in the, you know, near infrared. Also, I have about 2 hours talk on my YouTube channel discussing the NIRS in details. But basically, the NIRS is using the, you know that visible light is somewhere between 200 to 600 nanometer. And after that area, start the infrared, which is somewhere between 800 to 1400 nanometer. And in between, and if you know that the red color, for example, is around 610, 550, 90 nanometer. So if I use the prism and apply the red color on you, you will feel some hot. And by the way, the wavelength of the oxyhemoglobin is actually the same. So the NIRS use a wavelength from emitter at the tissue, and then it goes in arc like a banana shape and goes back to you, to the recipient. And during that period, it affected by the oxygen, and it measured the oxygen, not like the pulse oximetry, only the arterial line. It measured the oxygen in all the tissue. And because the vascular system is mainly venous and the arterials is less, so it's more venous weighted. So when it gives you the numbers, it actually gives you the amount of oxygen in the vein. But it also measures the artery, but it measures only like 25% of the artery, maybe 20%, and mainly it's measured the venous, and it's measured about 75 to 80. And because the pulse oximetry measure only the artery, then the difference between the artery and the vein, actually your oxygen consumption rate. And now you can measure the oxygenation, the local tissue oxygenation by NIRS at the brain to measure the cerebrum. You can use one, and you can use more than one. And actually, if you can use more than one, you can decode it to color shape and it can give you the shape of the brain in color by oxygenation. And you know that the brain are very active organ and consume all the oxygen. And all the organs are strive like a servant for the brain. And that's why you have the auto-regulation. And if you measure the somatic at the bowel or the stomach or at the kidney, you'll see that oxygen at the vein by NIRS are fluctuating up and down to keep the brain, okay, to keep the brain stable. And because the brain consumes most of the oxygen, then we expect the oxygen in the vein at the brain is low. And therefore, the NIRS of the brain usually lower than the somatic because the organs consume less. And therefore, their venous oxygen is higher. And they are very, very fluctuating. And they do that to keep the brain supplied. So the first thing that you will monitor within seconds when the baby start to compromise, you will see that they will lose this fluctuation. And then the tissue will use less oxygen and less oxygen. So you can see that the oxygenation of the somatic tissue will increase because you are measuring the vein. And until you reach the point, the auto-regulation will not work. And if you are not helping the baby, your brain start to follow, to be affected. Not only that, but also the NIRS can reflect your cerebral blood flow. So for example, if you transfer a baby and you do hand PPV and you do it fast, and then you watch CO2, you'll see your NIRS drop down because NIRS also reflect your brain blood flow. So it's very active and important tool. And guess what? When you do resuscitation, you monitor everything. You monitor the heart, you monitor the lung, you monitor the pulse oximetry, but you don't monitor the brain. And the brain is the organ you want to save. So if you go to my YouTube channels, and I can repeat the presentation, I can discuss cases, various cases. I think I have more than 30 cases to discuss and their pictures. And I can repeat the presentation of the NIRS specifically and the smart monitoring. But I have 2 hours talk on YouTube. You can look at use of NIRS in the NICU. I hope I answered your question.
Thank you very much.
Any more questions?
So yeah, we've got a question from Hadi in the audience. So he's asked about the sensitivity of ECG versus saturation monitoring. And I mean, do you find ECG to be more sensitive in being able to pick up the heart rate and more reliable?
Yes, there are very clear evidence that the sensitivity of the ECG is way higher. However, there is artifacts, more artifacts, because it pick up everything, all the electrical. There are better than ECG, which is the TIP, or the thoracic impedance plethysmography, is way sensitive than ECG actually. So the ECG are very sensitive, and the pulse oximetry are good, but it's less sensitive than ECG. So if you cannot monitor, and don't depend please on the fluctuation of the heart rate from the SAT monitor, because it depends on the nanometer movement, not on the voltage. So it depends on the wavelength, not on the voltage, while the ECG depends on the voltage changes. So it can pick up more, and the evidence are then, and also it's recommended by the LCOR, and also recommended by American Academy of Pediatrics to use ECG better than pulse oximetry or ausculting the, because sometimes the heart sounds are very faint, and auscultation might be not a good way, especially if you are doing chest compression and want to intubate and these things. So yes, I feel that ECG is more sensitive than pulse oximetry. However, remember that might be more artifacts.
Fantastic. Just one other question. So, and this is one that comes from Hadi again in the audience. So he's curious to kind of know, I mean, and this is a question that I pose as well. So when we do minimally invasive surfactant administration, and we practice LISA over here, the question from our perspective is we call it less invasive, but laryngoscopy is still probably the most invasive of the interventions in terms of handling the baby and handling the airway. So because you use laryngoscopy in both, do we actually think that, you know, minimally invasive surfactant therapy or less invasive surfactant therapy is actually less invasive? Is that related to the size of the catheter versus the ET tube?
I think if you're using your indicator of the term is laryngoscope, then it's invasive. I think the term less invasive or minimal invasive is allowing the baby to spontaneously breathe. I think the term comes from here. So by allowing the baby to spontaneously, because when you give surfactant, there is actually three forces driving the surfactant to the lung. The first one is your positive pressure. And if you have two balloons connected together, and one of them are old and a little bit open, and the one is closed, when you try to positive, the old one and already open will inflate, while the new one will not. So when you give surfactant by forcing it in, you're actually giving it to the already open alveoli, but whereas you want it to go to the stick alveoli, to the de-recruited alveoli. That's one. The second one is the negative force, the force that suck the surfactant in. And this created by negative pressure of the baby. And in this, you need to baby have spontaneous breathing. And for the baby to be spontaneous breathing, you need a room for the baby. So the larynx, the size of the larynx in a 24-weeker, about 2 millimeter. And for example, the vascular catheter and feeding tube of, size French size 5 or 6 is around 0.6. So you have around the baby about 0.4 millimeter that he or she can breathe in and help to drive that spontaneous breathing. Because when the baby wants to breathe in, they actually want to recruit their closed alveoli. And therefore, when they suck the surfactant goes to the closed alveoli. And that's what you want to do. So that's the reason why it's a minimal invasive, not because the term, because if you use the term laryngoscope, it's invasive. And if you use actually, you're catheterizing the trachea, they both are invasive. So, but the term non-invasive, I think, in my view, comes from using the spontaneous breathing. The other things that you want to use is the service tension. So the better the service tension, the more it goes, because the stick alveoli have a high service tension, and therefore it will suck the surfactant more than the open alveoli that have less service tension. So in that situation, you want the surfactant to go slow, but not very slow. You don't need to give it fast to close the upper airway, but you want to give it slow to cause some hypoxia. So I think the term of less invasive or minimal invasive comes from that the baby actually spontaneously breathing. I hope I answered your question.
That's really helpful. Just the next question. So would you routinely use sedation during minimally invasive surfactant? Because
yes, I do, definitely.
What do you use, Yahya?
I use fentanyl and atropine.
Okay. And for, say, do you use it in the delivery suite? And
yes.
How, because it takes us a long time to draw those drugs up. I'm just curious.
Well, it depends where and when you're giving surfactant. So in our unit, the resuscitation room is actually a satellite NICU. It's not a resuscitation room. So if you don't have that service, I think delaying surfactant is the good way to go, because you need to achieve, Dr. Sharma, you need to achieve that FRC before you're giving surfactant, because giving surfactant, you're actually not achieving surfactant, and actually your baby might not be breathing spontaneously. So hitting the baby with caffeine and having that FRC is the way to go before giving surfactant. And throwing the surfactant and warming the surfactant before the delivery, I don't think it's correct, because that's a waste of resources. So I think throwing the surfactant at delivery, that will take 20 minutes or so. And also achieving the lines and achieving, so it'll take about 20 minutes. So by best guess, the surfactant should be given within 30 minutes of life. By that time, I think you have fentanyl. Now, is it incorrect to give without sedation? I don't know the answer, but I think if anybody want to feel what is the type of putting something in the trachea and you are awake, you need to feel that feeling, okay? So I think a little bit of sedation is the way to go. Now, if you don't have the fentanyl IV, you can also give midazolam intranasal. That would a little bit help, a little bit sedate the baby. It does not cause complete amnesia, but at least it helped the baby to not jump, and also control your blood pressure, because we know that with intubation blood pressure goes up, and that might contribute to your IVH. So I deeply believe that you need to try a conscious sedation safely for giving surfactant, even if it's a minimal invasive.
Just another question from one of my consultant colleagues, Bala. So if he's asking if we struggle for access, is it okay to give caffeine orally? And how effective do you think intravenous caffeine is versus the oral route, especially in the smallest babies?
Okay, so I think that the best way to go is to try 2 IV lines, peripheral IV lines. And if you cannot, then I think you need to check your sugar. And if your sugar okay, you can wait. Now for the caffeine, I think you can give it orally, even if very sick baby. If the volume is small, you can dilute it in 5 ml and give it slowly. Now, how much it will action, and I have no idea. But I would say it's way better than intubating a baby. It's not milk. It won't, I think, increase the risk of neck. And it's a small amount. You can dilute it with a distilled water than dextrose, or you can dilute it with dextrose if you have combined apneas and hypoglycemia. Now, I know the evidence of glucogel is 200 milligram per kg in babies more than 35 weeks, but which is better, having some GI complications or having hypoglycemic encephalopathy or having a baby intubated? Now, do I have evidence? Unfortunately, I don't. But my feeling, and if you ask me, we are putting too much on randomized control trials. And randomized control trials are very small numbers. I think the way to go is neonatal network and collecting information. It would be wonderful if you have all the globe having neonatal data together and having because that will have a huge number of data to know the effect. But if I'm in your position, I don't have an IV, and my sugar is low, I would give caffeine, mix it up with a little bit of sugar. If I have no sugar, I will mix it with water and give it to the baby if I'm struggling with the IV lines. especially if I don't have skilled people are very skilled in doing arterial lines. However, if you don't feel that safe, you can always do low-lying UVC.
Yep.
I don't think you need time for low-lying
Yep.
UVC. You can always do it if you can do it in a sterile, non-infective way. That's
really helpful. Just another question. So the rationale of giving the caffeine within 20 minutes, I think Yaya's already explained, is to establish FRC and breathing in the baby. So somebody had just asked what the rationale was for giving caffeine within the first 20 minutes. I mean, I think, correct me if I'm wrong, what we want to do is make sure that our PEEP is actually working in a breathing baby, so aiding the respiratory effort. So,
yes, absolutely. So you cannot achieve that functional residual capacity by you. If the baby is spontaneously breathing, he or she trying to open the de-recruited alveoli, and therefore they achieve better functional residual capacity. That's one. Second, we know that about 25% of babies are actually intubated not because of respiratory distress, they are actually intubated because of apneas. And therefore, giving this caffeine early will avoid that apnea and will achieve better functional residual capacity and will help you to improve your outcome with LISA.
okay.
I think that would be the answer, but I might be wrong. I might be not clear about that, but I think that would be my rationale of giving caffeine. And it's very clear for us because our chronic lung disease is way lower than other people.
That's really helpful. Yeah, that brings us to the end of this question session. Be very happy for you to carry on with the presentation, please. Thank you so much.
Great. So again, if you guys remember, we were talking about not only looking at babies by our visible eye and our monitor real time. Well, we can look at babies in different ways. And even if the same output, we can present it in a different way, such as histogram or tachogram or point care or frequency table. That gives you the centralization and lateralization of your value or scatterness of your values. That will help you too. You can use a tachogram that will give you the idea about event-to-event variability. You can give it about point care that it will give you the physiomarkers, which is your shape of your physical output, so your shape of your heart rate. So for example, if you give me 10 people and I do point care of them, and then give me another 100 people and put that one of these people inside, the system will know which one that baby. So I can identify that baby or that person from the point care shape. Not only that, the same patient, different disease status, can be recognized from the shape. So point care, very good tools to give you the shapes of your physio features, or what I call it physio patho features also. And I have very good publication about that. I have 2 articles if you want to Google it. And talking about the tachogram and point care and how we use that. I'm going to talk about a little bit. So not only using the usual physical output, such as heart rate, respiratory rate, saturation, but we cannot use it only in real time. We can use it in a different way of presentation, but we can add different tools to look at the baby. Now, when we measure the mean blood pressure, we're only talking about the arterial side. But remember, there is organs, there is venous side to contribute to the cardiac output. So measuring the cardiac output or the blood pressure alone won't help. Measuring the returns also won't help. You need both the going arm and the coming arm to know whether your cardiac output are actually affected or not. It's vital to use that when you make a decision about your cardiac output. Now, there are many markers that we use it for perfusion. But remember, all these markers are planted and they start to build up after the baby actually gets injured. So you can see in these diagrams that once the damage or the poor perfusion start to occur, The first thing will be affected is the regional oxygen saturation, especially the somatic, because it has the autoregulation, and the autoregulation is immediate. So when you're standing and then sitting or lying, your autoregulation will change. So even your movement, the regional oxygen saturation will be affected in the somatic. In the cerebral will be a little bit later. The pulses will be like within minutes. The color will be like within 30 minutes. The capillary delay will be like an hour. Cold extremity maybe 2 hours. And then you start to have lag time. Would need about 3 hours to build to get your lactate. And remember, when your lag time build, even with your correction, there will be lag time for clearance. So remember always to build that. And after lactate will build, you'll see that lag. And here, after lactate, you'll see the blood pressure change. So the blood pressure actually change is a late sign. And the blood pressure sometimes change to compensate. So you might have low blood pressure and you don't need to interfere. And sometimes you actually have high blood pressure and you need to interfere. And then at the end, you have the oliguria, and then by the end, you'll have the kidneys affected. So having NIRS, regional oxygen saturation, give you that sense. Not only NIRS, but that is the most common available in the market, but there are other tools that you can use, the infrared camera, the visible light camera. I'm going to show you a picture how we use visible light camera to actually measure your blood pressure and other features. So we can use also the point of care ultrasound, looking at the head, or whether it's a pathology, bleeding, or the Dopplers, and assessing the perfusion and cerebral blood flow. We can use it for the lung. And, if you look at the evidence, the sensitivity of the ultrasound in detecting various lung diseases, such as RDS, DTN, pneumonia, are up to 95%. And the specificity is very high. So any disease can be diagnosed by X-ray, can be diagnosed by lung ultrasound. And people saying interpretation, I don't think there is a difference between interpretation of X-ray and interpretation of lung ultrasound. Both you can do mistakes, both you can be wrong, and both sometimes you need help and discussion, and both sometimes you need a radiology opinion. There is no difference. But you need just courage, and you don't need to be lagger. You don't need to be late minority, and even you don't need to be late, late majority or late minority. I don't tell you to be early minority, but at least be early majority of implementing these things. I think the doctors, the physicians should be off stethoscope and X-ray. I think ultrasound is the way to go. And ultrasound should be trained by medical students, by nurses and physicians. And there's time the stethoscope will go away, the echoscope will come. So also you can use it for the heart, for the bowel, and of course you can use it for procedures, lumbar puncture, intubation, chest tube, feeding tube, transpyloric. You can use it all. You can use it for intubation, as I say, and you can use it for vascular access. It can help you increase your success from 60 to 70 to up 90%. So I'll give you here a quick review about, quick session about lung ultrasound. So what we do is we use something called profiles. So you can see we have different profile. We have A prime, we have A, we have B, we have B prime, we have C, and we have F. So A prime, where there is multiple A lines, and then you have no sliding. While A, when you have the sliding and you have multiple A lines. Where B, you have separated B lines with the sliding. When B prime, when you don't have B lines, when you have B lines, but you have sliding. And C, when you start losing the lung architecture. So and F line, when you have more fluid and pleural effusion. And this goes worsening, and this is improvement. And this means more air, and this means more fluid. And by this, you can decide how much fluid you can give, how much ventilation you can give, when and how to give surfactant, how to give, by simple one picture, if you're trained, whether you need Lasix or not, what type of heart failure you have. Is it peripheral, you need inotropes, or is it cardiac? So but by one simple teaching of 2 hours, you can have lots of information that you can take it from lung point of care ultrasound. You can use, of course, in lung ultrasound, we use the 12-zone system. We don't use the blue protocol because I think 12-zone system is way better because it gives you idea about the 360 degrees of the lung. But you can, if you don't have time, you can use the blue protocol, or you can use Lucy or Fall protocol. We use bowel POCUS. So we use the ultrasound to measure the sections and the windows in different 5 regions. We look at the 13 signs of necrotizing enterocolitis, like ileus, bowel movement, intramural gas, intraperitoneal gas, intraperitoneal fluid, bowel wall thinning, bowel wall thickening, hyperemia, hyporemia, and so on. There are 13 signs that you can look, and you can measure the Dopplers, the diastolic velocity of the subeomesenteric and the Seplanchnic and the renal. You can also measure the diameter, and all that helps you. And the evidence are very clear, help you to diagnose the bowel pathology such as neck or sick bowel. You can use ultrasound guided vascular access to tell you the vein and the artery. And with the current level ultrasound that can close up to 0.5 centimeter from the skin, you actually can do the arterial line, even if it's peripheral, but you cannot do the peripheral line. You need another means to do peripheral line IV, but you can use the central line from the antecubital fossa, axillary, subclavian, femoral. You can all use to train yourself using the color, the 2D, and also the Doppler to localize and follow your guideline, your tip of the needles. And of course, you need training of that. But the success rate of doing ultrasound increase, minimize the punctures times, minimize the repetition, less sedation, less manipulations, and that's mean less infection and better outcome. The heart POCUS, of course, is vital to assess the heart, and is not difficult for a neonatologist. Few windows, and each window, a few views and cut, and then assess the heart. And if don't listen that people that you cannot interpret, you are not cardiologist, you are not a structural echocardiographer. But if you put a plan that my picture should be reviewed by the cardiologist within 24 or 48 hours, just to say there is structural malformation or not, that is the way to go. So I think heart POCUS will help lots in decision making of very compromised cardiorespiratory patients. Now, there are other things that you can use to monitor baby, such as contactless imaging using visible light camera. So you can see here is the visible light camera that measure about 700 frames per second, and our eye can see about 25. So this is very fast. So it takes the frames and then decode it to RGB, to 3 colors. And remember that the red color is the same wavelength of the oxyhemoglobin. So the red color will give you the oxygen saturation. And if you measure the IPPG, same like oscillometry in the cuff, at 2 points, it will give you the PTT. And the PTT will give you the blood pressure. The change in the PTT over time will give you the heart rate. And because you have all changes give you the perfusion, and they give you the maximum represent the end diastolic and the minimum represent the end systolic, and the difference is the stroke volume. Because you have the heart rate, you get the cardiac output. And because you have the perfusion and the cardiac output, you can get vascular resistance. That is autonomic continuous if you have to adopt this technology. You can use the frequency table instead of looking to the graphs. Look to the line. So it gives you the average, the mean, the centralization, the lateralization, the standard deviation. It gives you the range. It gives you the interquartiles and so on. It gives you the frequency and so on. It gives lots of information from looking in last time blocks such as 8 hours, 16 hours, or even 24 hours. You can use the tachogram. So this is an example of a tachogram of a baby. So you can see in sleeping time, the variability drop. While when the baby have a peaceful feeding time, the variability is less. But see when there is pain, when you examine the baby, look at the variability. It goes everywhere. So you can see when there is bradycardia, you can see when there is tachycardia, because the time, the interval is being shorter, and this is here becoming longer. So you can see this, how time give you whether your baby was sedated, whether your baby was happy, if there is any changes with the baby, if there is sepsis, and so on. So tachogram can give you a very good idea about event-to-event variability in last time or block of time. So you can use histogram, whether it's heart rate or NIRS or saturation or heart rate, and it tells you the percentages and the time and the numbers that the certain physical output is stayed in certain period. So you can have skewed, positive and negative, you can have it centralized, you can have it scattered, and you can have it lateralized. And all this will give you whether you are hyperoxygenated in here, NIRS, or you are hypoxygenated, or you are within the normal, or you are very extreme because the baby is not sedated, for example, in here. So this gives you a very good estimate of the previous performance of the baby. This not give you event-to-event variability. You can use the tacho or point of care, and the point of care, it gives you the shape of the baby. Usually it does not change with time, but usually each baby has his or her own shape. So you can see the shape of 24-weeker, you can see the shape of term baby, and you can see the shape of baby with heart block. And it gives you a different thing. It gives you the standard deviation, it gives you the average, it gives you the identity, it gives you the shape. And sometimes this shape with certain diseases. So this is very important print. So as if you are fingerprint, you have retina print, you have face print, you can have your physiomarker print. And please refer to my articles about this, details of this, how this enough and can be done. And it's very simple. There is no big deal with it. Just if you have it built in, if you don't have it, just know the format, how your company save the data, whether it's a comma format or it's a dot format, and then take it to Excel. I provide you the program and we'll build it for you. It's not that difficult, but you need to take the data, the format that your company saved the data in. All these data are lost. So in single monitor, it's lost after 24 hours. In the station, lost about after 5 or 7 days. But give you very valuable data and you don't see it. You can use the linogram and you can see how the linogram here of the somatic and the cerebral NIRS are changing, and the variability of somatic and the stability of the cerebral. So you can use the linogram. You can also compress it. So you can take 24 hours data like this blood pressure and compress it over 30 minutes and it gives you shape. And you can see the difference between the systole, diastole, and the mean. And you can see how here they become, despite the baby become sick, the blood pressure went up and become very close and pulse pressure become narrow. So it gives you lots of data, and you can see we don't depend on numbers. We just look on the graph and look, give us valuable data. Is these lines going away from each other? Are they coming closer to each other? Are they moving together? And so on. And you can see here how was separated, and all of a sudden, when somebody did some actions, okay, when hypotension and lactic acidosis, how the blood pressure become not very much different, but the systolic and diastolic become closer to each other. And you can see when the intervention happened, how it becomes back to where it was. This is my monitoring device, look like a monster. In the resus room that I use, I can record up to 24 channels. This is for research purposes. And the tools that I use, this is the thermal camera, this is the NIRS, this is the visible light camera. I use NM3 monitor to connect to the ventilators and other monitor. I use the respiratory inductance plethysmography, the AEEG, this I connected to RIP, and also I have the audiography to connect, and my monitor, of course, touch, and it's a ergonomic stand, so I can move it anywhere I want. I can see that the channels that I record. And I'm going to give you example of the infrared camera. So look at here. This
I
the
didn't
X-ray.
understand that.
This is the X-ray. Okay. And look at the infrared. Look how the bowel are hot. But look at the X-ray, not much of the changes, a little bit of global gaseous distension. But look at it. This is from a study in Duke's University, and where they can suspect the neck 12 to 24 hours before it happened using infrared camera. Look at this. Look at this bleeding. So because the bleeding, when it goes out, it cools down. You can see how you see it in the thermal camera, and you can see it expanding, such as subgaleal hemorrhage, or small, and when exactly happened, and you can monitor it. You can monitor it, especially if you have dropping hemoglobin. This is the RIP that I use. So you can see there is dots here, and they have name. So this is anterior, chest anterior, this is abdominal anterior, this is posterior, and so on. And these moves, and these are connected by a stretch. So once the baby stretch out, the algorithm in the system will calculate it. So you'll have the baseline, and you have the expand, and you'll have the relation, global relation and relation between each one. And therefore I can measure your PEEP, your PIP, and your respiratory rate. I'm not touching you. And the beauty of that, I can measure it while you're intubated, while you're ventilated, and it's the same numbers. They won't change. So you'll see the pattern. We can use the TIP, changes in electricity in the ECG, and measure the respiratory function. And we can use the CGI, computer graphic, and we could use two modes, whether it's a scanning or it's expectation. The most important point is also feeding, how to initiate, when to use the MEF, how to advance, what's your delivery method, what's your guideline for donor, express, or formula, how you use the additives, and how you treat complications, and how you deal with residuals, the big problem residuals, why they are done. And about POCUS, of course, whether you use OGT or NAGT or transpyloric or gastrostomy, you give bolus or intermittent or continuous feed. And here I'm going to show you a protocol that we use. Now I know the protocol, there is no evidence, but it seemed that when the protocol are used, there is organization of work and a better outcome. So you can see this is an example of protocol for 600 to 699. So it describes everything for the doctor and the nurses and the OT, the occupational therapist and the feeding team. And it have everything by selection. So even if you don't have system, you can still use it in Excel format, or Access. If you have system, then you can see it helps them by selection, and you can select everything you want, and it's alarming them when and how to change. And you can see the MEF giving by 3 days and giving one more option days for the doctor, but you can stop it. This is the standard sequence, but the doctor can move faster or slower, but they have to give an explanation, because the executing people might not follow these because they have these guidelines. And I have more to say, but I think I have to stop. I took a long time, but I would be happy to answer questions if any. And if people interested in NIRS and smart monitoring, I can give talk on that. Thank you very much. I appreciate your listening, and my apology if I took a long time.
So,
Thank you. It's amazing.
Thank you. Yeah, we're really grateful. I mean, that's an absolutely amazing overview of how quickly you guys have progressed, especially with the smart monitoring. And, I had the benefit of being able to listen to Dr. Yasser's kind of talk and workshop, but this is absolutely amazing. What I was going to do is just open the floor to any questions from the audience. Anybody wanting to ask any particular questions? So a question from me, I just with the smart monitoring at the moment, do you have bed spaces? Are all your bed spaces made up with the smart monitoring that you've shown? And just in terms of being able to set that up, especially for extremely preterm babies, how many nurses do you have looking after the baby? I mean, at the moment we really struggle because we can't even achieve the one-to-one care. But I'm just curious, how many nurses do you have looking after the baby and the monitoring? Or do you have an RT and a nurse for every baby?
Well, you have RTs. We have 40 RTs in the unit. We have, I think, 256 nurses. We have, I think, right now, I think we have 12 fellows.
Doctor.
We have 20 specialists or registrar, or they call it HMO. And I think we have 13 consultants. But we do very high risk. So our NICU is 75 beds in total. And I think using smart monitoring will decrease the number of nurses, especially if you use dynamic CPAP or dynamic PEEP and dynamic FI2 control. That would, put a limit upper and lower and let the machine help you. Regarding your question about smart monitoring, do you install it in all computers? The question will be no. It depends on the money. Do you have money? Are you rich? Then you can put it in all the computers, yes. But if you don't have, what you need to do is depending on the situation and depending on the nurse and the RT. So if you're interested in ventilation, then you can do smart monitoring on that. And if you're interested in outcome hemodynamics, then you can do on that. And depend if you have built-in system or you have your own system to do that. I use my Excel because most of the company not allow me to enter their data. So I take the data out by using RS-232 port to my computer, and then I monitor the data. What you can do, you can buy a cheap computer like $500 or $1,000 and install these programs and make it live. You can use it using RedCap, the research data entry program, and it can be live and you can access it remotely. So technology has been changed and it makes everything cheaper and cheaper. So again, the talk about smart monitoring is like very way to go. And there is, I think, was annual meeting in Milan about smart monitoring, but it's more in adult. I think in neonatology, we are lagging behind, neonatology and pediatric in general. But I would be happy to present like heart rate smart monitoring, blood pressure smart monitoring, pulse oximetry smart monitoring, and also NIRS smart monitoring. We can discuss it as cases, or I can do the principles and clinical applications. I do have 2 articles about it, so if you guys want to search, you will find it. One, I am the principal author, and the other one I was like a co-author.
That's fantastic. Are there any other questions from the audience at this stage? I'm going to end the session, Yaya, by a vote of thanks from everybody, and in particular from our network. Thank you so much for what was a fantastic presentation and, a completely new perspective. I think looking at the way you're doing things at the moment, in particular, I have had a few requests for the checklists that you are using. So what I was going to suggest is if I email you and if you could share them, it would be fantastic. Sure. That would be extremely kind.
Absolutely. My pleasure.
Lovely. Thank you so much. And thank you to everybody who attended today. Just a reminder that we'll be talking about NEC. So Nigel Hall, consultant pediatric surgeon, will be talking about NEC on the 25th of November. Wish you all a great day, and thank you so much, Yaya, once again. I'm so grateful.
Great. Somebody is asking about the checklist, but I will forward it to Dr. Sharma, and he can forward it to. And I hope Dr. Sharma record the presentation. I don't know if it was recorded or not.
I have recorded it, so I will be able to share it with my colleagues.
Great. Great. Thank you very much. Okay. And I will share any resources, including NIRS, smart monitoring, checklist, anything, you guys. And if you can go to my YouTube channel, you will find some resources.
So I would be very happy. I'll share that with the network with your permission, Yaya. So I'll send it to YouTube.
Thank you very much. Thank you very much.
It's absolutely pleasure.
Thank you. And my apology because I took a little bit longer time.
No, just another note. I mean, for the people who are interested, I have actually trained under Yaya doing his lung ultrasound course, and I can't recommend it enough. So, for those of you who are interested, I will BCC Yaya's email to you. If you're interested in attending his lung ultrasound, I'm going to be doing the bowel ultrasound in due course as well. Please don't hesitate to get back in touch with him. But thank you to everyone.
Dr. Sharma, I do six courses: lung ultrasound, lung POCUS, head POCUS, heart basic POCUS, heart advanced POCUS, advanced hemodynamic, smart monitoring, and also I do bowel POCUS.
It's really kind. Thank you. And I wish you all a very good day. Thank you, sir.
Thank you very much. I appreciate it. Thank you very much. Have a good day. Bye-bye.